Coming up today, radiation delivered through an IV. See how these newer therapies are helping people living with metastatic cancer. Good morning. I'm Jessica Lovell, and welcome to the Morning Medical Update. Today, we are continuing our series on prostate cancer, the most common non-skin cancer among men. As we have learned, it is highly curable when caught early. But what happens if the cancer has spread? We are about to meet someone who has endured years of treatment for metastatic prostate cancer. And more recently, those treatments have included 2 different radiopharmaceuticals, also known as radioactive drugs. Today, we are learning what it means to have radioactive isotopes in your blood. How do they find the cancer and not find the healthy tissue? We'll also learn how the side effects compare to typical radiation. Joining us here at the desk today are 2 medical oncologists and experts in genitourinary cancers, Dr. Raul Parikh and Dr. Elizabeth Wolf Birchfield. Good to have you both here to help us really and teach us about these radiopharmaceuticals. Thank you for being here. And we are also joined by one of Dr. Parikh's patients. We have Tim Pierce joining us via webcam. Tim, good morning. How are you?
Good morning. I'm doing well. Yes, thank you.
Well, we're so glad you've come to share your story. Tim, I need to point out that your cancer care started at a different hospital, but take us back to 2015. How old were you then, and how did you find out that you had prostate cancer?
Well, I was 60 years old then and a little bit past due on a colonoscopy. I had that done, and during the process, the procedure, they discovered that I had a swollen prostate. Further tests and biopsies revealed that it was indeed prostate cancer.
So you learned you had a PSA level of over 100. Did you even know what that meant?
Well, honestly, I'm ashamed to say I really didn't. I knew about PSA, but the readings I wasn't really familiar with. And interestingly enough, if you will, when the doctor told me my PSA was, I think it was 101 or something along those lines, I had no idea how severe that was. And when I asked him what it should be, he said down around 4 or less. I was truly shocked.
Well, and no shame in the game, Tim, because you're not the only one who might not know what even a PSA is. Know to go get checked, and good at least, even though you were a little late on that colonoscopy, at least you were getting that screening. So good for you there. What treatments did you go through to try and lower that high number, that high PSA number?
Well, I think initially there was an androgen deprivation therapy, if I'm not mistaken, that helped bring the PSA down a bit. That was followed by radiation treatment. And later in the year, that being, of course, 2015, that worked for a while. Then in 2016, follow-up exam showed that my PSA was starting to rise again. And late in 2016, I did my first round of chemo.
So you did radiation, then chemo. Tell us about the side effects. How did you handle those? What were they?
Well, on the radiation, not much that I remember at this point. The challenge there, of course, was that prior to the treatment, I had to make sure that I had a full bladder. So that, again, presented somewhat of a challenge. But beyond that, the radiation, I think I'm sure I was tired there for a while after the treatments, and maybe a loss of appetite to some extent, but not a lot. I didn't have much in the way of nausea or anything along those lines, or if it was just slight. And basically the same thing with the chemo, maybe, but more of those side effects with the chemo being, say, more tired. I think I did have more diarrhea or some sort of effect similar to that, of course, being constipation. And just more tired when I used when I was getting the chemo treatment.
So you're trying these different these different treatments. You're putting up with some of these side effects, but then 2 years after that diagnosis, you learn that the cancer has spread. It's metastatic. Tell us where it spread and just how did you deal with that news?
Well, it has spread to the lymph nodes, and I sort of expected it. My previous examinations indicated that there was that possibility. I didn't like the fact that it had spread. It sort of darkened my my outlook, so to speak, to some extent. But I knew I was getting the finest treatment around, so I just hung in there.
Tim, you're doing a really good job of kind of walking us through this journey, because next up you start new chemo treatments, including a chemo pill. You were also getting targeted radiation for tumors growing on your bones. We've heard that is very, very painful. How would you describe that pain?
Well, it was different. It was not exactly what I expected. I knew there would, had been told, educated, that there would probably be some pain, and I was already experiencing pain. But it was just more of a nagging pain. And in my case, it was in, I think, in the collarbone, clavicle, if you will, and sort of in the upper back or neck areas. And it felt more like I just worked out a little too hard. But unlike back when I would work out and maybe experience similar pains, it just wouldn't go away. And over time, it kept getting worse.
So recap, diagnosed in 2015, metastatic by 2017, and then fast forward to 2023, you first came to the University of Kansas Cancer Center. So how did you end up seeing Dr. Parikh? How did you guys connect?
Well, my oncologist at the previous hospital, that was the Sarah Cannon Cancer Institute there, it referred me to Dr. Parikh, and I've been with him ever since.
So, Dr. Wolf Birchfield, I know Tim is not your patient, but what stands out about Tim's story as you're hearing it unfold?
Sure. I mean, this is a relatively common experience for folks who are treated by a genitourinary medical oncologist, in that while I know there is this perception that prostate cancer can be only an indolent disease, it can be very aggressive. That's exactly what he went through, in that he received, it sounds like very high quality, comprehensive treatment at the outset, but his cancer was just very smart and recurred, or really sort of persisted and then started to grow and take root in new places. But I think, while that's not anything, I mean, that is common for the patients who Dr. Parikh and I treat. I think it's important to know, and again, while our focus right now is on Tim's lived experience with cancer, I do think it is an important reason to emphasize why screening matters. Which we, if we have time, hopefully we'll be able to talk about.
Always, screening is key, because then if we have screening, then we never need to have you guys in here talking with us, right? And we can hopefully battle some of these things a little bit earlier. But Dr. Parikh, we have the smart cancer. We need smart doctors. Dr. Parikh, I'm looking at Tim, and this big guy and seemingly healthy and doing all the right things. But how'd you get to work to help find a treatment path for him that could get him better?
Yeah, so we walked back, and exactly what you showed here is we looked at what treatments Tim had received so far. We also looked at how well he's doing. And our goal was, yes, we want to improve his quality of life in addition to making him live longer. So those were our two objectives, and we talked with Tim about that.
So sometimes we hear that word metastatic. We might think the worst, and that's changed a little bit over time, because now we think of it maybe in terms of managing cancer like a chronic disease, right?
And I think that's exactly right. We think about cancer as being a death sentence, and that's truly not so. A lot of times patients with metastatic cancer can live on for a number of years and have excellent quality of life. It is akin to type 2 diabetes or hypertension, which can be controlled with drugs or medications. And that's what we talked with Tim about.
Dr. Wolf Birchfield, I see you nodding your head, because the conversations with patients are much different now when it comes to metastatic than it was decades ago.
Yes, thankfully. It's such a privilege. There's no good time to have cancer. But there is a good time to be an oncologist, and that's now. We're in the golden age of oncology now, in that we have treatments that can help people live life. I think there's this perception that oncology is about dying, but it's about living. And we have patients, I mean, we get to celebrate their wonderful milestones of, meeting, getting to retirement, or, getting promoted, or having their first grandchild, doing all these important life milestones because their cancer is controlled. And so it's such a privilege.
It's fun to see all that unfold in real time and for a long time.
Yeah.
So, Dr. Perry, you started Tim on a radiopharmaceutical called Pluvicto.
Correct.
It was FDA approved in 2022. And correct me if I'm wrong, Cancer Center is the first and only place in the region for this type of treatment available. Is that correct?
So that is exactly right. In the state of Kansas, we are the only site that kind of does this treatment with Pluvicto, both in 2022 and currently. So that is exactly right.
So we have video of it being administered, but from this perspective, it looks like any other IV treatment, all in a day. Explain how Pluvicto can find and treat cancer cells, but not hurt the healthy cells. Either of you jump in.
Go ahead.
Yeah, so Pluvicto, it's a radiopharmaceutical kind of agent, as we discussed. It basically is directed to a protein that is present on the cancer cells called PSMA, or prostate-specific membrane antigen. And it is directed to that specific target that sits on top of the cancer cells. Essentially, it consists of a radioactive isotope that is linked to the targeting molecule, and this targeting molecule searches for PSMA, that's the protein on the cancer cells, on the prostate cancer cells.
And we're seeing this here on the screen to help people like me understand what it's doing inside the body.
Yeah.
Dr. Wolf Birchfield, the word radioactive kind of comes with some baggage, if you will, but putting radiation inside the bloodstream sounds scary. Yeah. Are these drugs dangerous?
Well, I think we could say that they have a narrow therapeutic index, and that this is, for example, something that has a wide therapeutic index might be a blood pressure medicine, in that essentially any adult is going to get the same dose and can take the treatment at their home safely. But this is something that needs to be highly monitored, administered, prepared, and administered by experts, and that's what we do here. I think any site that's administering a treatment like this would also be doing that, because there's such rigorous oversight. But these treatments are safe. They've been demonstrated to help people live not only longer but better, and so only safe treatments can do that, even though they have risks, they have trade-offs, but they are safe for patients and for their family members, as long as patients and family members are able to follow the necessary guidelines.
I was talking about this yesterday, and you have to take me back to my science class and help me understand. So when something is FDA approved and it's targeted, a question we often get from our audience is, well, what else can it treat? This only treats prostate cancer. Is that what I understand? And then my next thing is, why? I mean, I know all cancer cells aren't created equal, but why can't it go in and attack other bad cells?
So basically, we identified a unique protein that is present just on the surface of the prostate cancer cells, and that is the reason why this kind of treatment targets only the prostate cancer cells. It may have some side effects. It collects in kind of the salivary glands and kind of the eye glands, and so you could have dryness of your eyes or a dry mouth. But beyond that, this is a highly specific treatment for prostate cancer only.
All right, Tim, let's bring you back in to talk about this. How would you compare your Pluvicto treatment to those previous treatments that you had received?
Well, it was the side effects I experienced were a lot less than what I expected to experience, having this type of treatment. I was a little tired. There was a bit of a loss of appetite again, maybe a little weight loss, but overall, I thought I did very well with it.
So was there a period of time that you yourself, you were radioactive?
Yes, up to about a week, I had to limit my exposure to other folks distance-wise. I think it was like 3 feet or more for a few days right after the treatment, and then a little bit less for the remainder of the 7 to 10 day cycle. After that, I was fine. I, slept away from the wife, used my own bathroom, and washed my own laundry during that period. To sort of limit the exposure to the family and others.
That's so interesting. You said that's just the way it works. Yeah, it's an interesting side effect.
Yeah, and there are some other radiopharmaceuticals that have similar restrictions and some that don't. So for example, for thyroid cancer, radioactive iodine also has that period of radioactivity, but we don't see the same sort of restrictions with all agents, including, radium-223. Things look a little bit different, which is Xofigo.
That's exactly right.
Yeah.
So we have more questions for our doctors and for Tim. So be sure to ask your questions if you're watching us live. You can use the chat on YouTube or Facebook. You can email the Medical News Network. All of that information is right there on your screen. So Dr. Parikh, Tim was taking Pluvicto. How long is that regimen? Can that be repeated?
Yeah. So that's a series of 6 treatments generally. It is given once every 6 weeks, generally a short infusion. We usually check restaging scans every 3 months. We check blood work usually every 4 to 6 weeks to make sure that someone is responding to these agents and not having or developing any major side effects. And as long as they are responding without much side effects, we continue for the entire duration of the 6 treatments over 6 weeks, which is 36 weeks in all. Generally, we do not repeat these treatments because the concern is how it may affect bone marrow and other organs.
But he is on a different radioactive drug that attacks his bone metastases. Is that correct?
That is exactly right.
How is it different from Pluvicto?
Yeah, so this is, like Dr. Bursfield pointed out, to Xofigo, which is an alpha emitter. So it is a different type of agent which has been FDA approved for treating patients with prostate cancer, mainly with bony metastatic disease. And it does not affect or harm the bone marrow and other organs to the extent that repeating something like Pluvicto may.
So Dr. Birchfield, what makes these drugs less toxic than chemo?
It's really their specificity. And truthfully, there are times when things like chemotherapy have more value because we need something a little bit less specific. And so, but in this case, when it's a good match for a given patient, being able to take the radioactive particle to their cancer wherever it is in the body, this is sort of a negative reference, but I often describe it as a heat-seeking missile. Something that's going to search and destroy their cancer, whether it's in a lymph node or bone or even in an organ. And so, but being able to take it to those cells has so many fewer effects on healthy tissues because they don't take it up to the same degree. Although Dr. Parikh did mention that there are some other cells that have PSMA on them. You might say, well, why, if it's a prostate specific? I mean, we created that term, so while it's most heavily expressed there's some expression in kidney and salivary glands, some of the lacrimal glands as well. But it's all about trying to deliver it right to the offending cells.
We're coming after you.
Yeah,
I like it. You're like the missile. The cancer, we are coming after you. Exactly. So how does the reduced toxicity translate then into that higher quality of life for a patient?
Well, that's been shown repeatedly in clinical trials, thankfully. So we know that this is a real phenomenon. So there have been a few trials that have compared quality of life for patients receiving Pluvicto to things like chemotherapy, and even in a more recent trial that came out about 11 months ago to switching to another hormonal agent. Part of the reason is because quality of life is driven in large part by someone's cancer burden. Growing cancer makes people feel badly. It makes them hurt, it makes them tired, it makes them lose weight. So controlling their cancer in a comprehensive way helps them to live better. There are always these off-target effects that also are the trade-offs for controlling their cancer. And with something like Pluvicto, there are fewer of those. So in these trials, we've seen that quality of life driven by cancer control, but also the specificity, so there are few of these off-target effects, is just superior with Pluvicto in a number of circumstances.
All right, Tim, does that sound about right? How are you feeling? What's day-to-day like for you?
Surprisingly well. I have plenty of energy, more than I thought I would have. I'm able to do my exercising and just interactions normally. I can't say enough about the treatment, honestly, because again, I thought I would have more adverse side effects of it, from it, I should say, but that hasn't been the case, at least so far, and I'm doing quite well.
Tim, we know there's a stigma around the prostate and that area down there, and we're always trying to fight that. That's why we have these open conversations. I'm just curious, do you talk with your friends, other guys, about your experience?
Yes, I do. Prior to being diagnosed, I thought I was the epitome of health. I worked out all the time and, weight lift and all that. And it's interesting, I have a photograph, a selfie I took maybe a month or two prior to being diagnosed, and I look at that often and think, that is what prostate cancer looks like. That is what a man with prostate cancer looks like, knowing that there are no signs. So I make sure to talk to my coworkers, one of whom has his own battle with prostate cancer going on. My family members, I have 2 sons. I discussed it with them, and just any other individual, male individual, that I come in contact with, about the necessity of getting regular checkups, knowing what their PSA is, and so that they, don't delay any treatment that might be necessary too long.
Tim, you said it perfectly. We're all, that's like music to these doctors' ears. We love hearing that you're out there spreading the word, and being the face of somebody who's gone through these treatments and who's living life again and getting those screenings. Dr. Wolf Birchfield, remind us of those prostate cancer screening guidelines.
Sure. This has been an area of controversy, and I do think that I know that Tim said he felt sad about not having had prostate cancer screening or as frequently as he wanted, but gosh, I think even a lot of physicians don't know the right answer for what to recommend for their patients, or haven't all the time. Certainly not the fault of the consumer, the patient. So right now, the way that guidelines are mostly structured is that prostate cancer screening is recommended to start as early as age 40 or 45 for high-risk individuals. So men who identify as Black, people who have a family history of prostate cancer in a first-degree relative, or who have an inherited cancer syndrome, and there are several that they could have. And so that's quite early, and that's starting with PSA testing. Again, 40 or 45.
Know your family history.
Yes,
so
know your family
if you qualify for those early screenings.
And that's not possible in every family, but gosh, whenever possible, trying to know that can help save your own life. And then for men at what's felt to be an average risk based on their family history or any known genetics, men are encouraged to start around age 50, and generally the frequency should be determined by shared decision making between physicians and their patients, and same with the timing of beginning screening. So this is certainly a part of shared decision making. This is not cookie cutter, but often is about every other year for men, and the duration of that is really dependent on someone's overall health, because we used to have a very strong cap at a certain age, but gosh, if we think someone naturally would live to be 95, we really want to extend that until they're 10 years earlier than that. So
any data on how many men are actually getting the screenings? Are we getting better? Where's the work need to be done?
Right now, work needs to be done everywhere. I think that what we are seeing is that the frequency with which people are undergoing the recommended screening varies by their age. So for early screening, these young men 40 to 50 who have high risk, the rate's only somewhere around maybe a quarter of patients. We do better in the subsequent couple of decades and then worse again. So I think it's somewhere between about a quarter to almost a half of men, depending on their age.
But it goes back to the conversation about the stigma and trying to erase the stigma. Dr. Parikh, what kind of conversations should people be having, around the dinner table, with their friends, on the golf course, and certainly with their doctor.
I think overall it's always easier to treat someone with early diagnosis in terms of getting them to achieving a remission or a cure from prostate cancer than detecting it late and trying to kind of manage or salvage the situation. And exactly what Tim pointed out is he spoke with his family, his 2 sons, about getting screened. And I think that's a very important concept where someone goes through that and kind of tries to spread the word around.
It's like the ripple effect.
Exactly.
I hear Tim talking and I keep thinking he's one person, and if he were to just sit there and say nothing, but the fact that, Tim, you know so many people and friends and family, do you get a lot of questions, and what are those like? And you must now feel more comfortable talking about it, knowing that you might save lives.
Yes, I do. Some of the questions basically are about the treatment that I'm receiving and how I'm tolerating that treatment. And but I always tell them that, hey, you know, it's not as, for me anyway, it's not as bad as you might think if you have it. So don't put off getting screened to make sure that you catch it early if you do have it. So that's basically it. I just try to, you know, talk to as many folks that I feel comfortable talking to about. I mean, I don't come up as strangers on the street sometimes and start talking, but I try to spread the word as much as I can through my associates and family members.
Yeah, you're doing a great job. I want to get to some questions and comments from our viewers this morning, and Jill has a good one. Family support, as we know, it's so important. Tim, was it difficult explaining to family, especially any little ones, that you couldn't hug them or be around them during that treatment?
It was a little. I do have some grandchildren. I'm blessed with some grandchildren that live nearby, and they come over quite regularly. And one of the first things they want to do is give me a hug. And I had to, you know, tell them that, well, you know, I can't hug you right now. It'll be a few more days. But, you know, I was able to be in the room with them, or, you know, go outside and watch them play outside. But I think they understood. They may not have understood the details as to why, but they knew old Papa Tim was undergoing some treatment. And because of that, I had to keep away from them for a while just to make sure they were safe.
Yeah, so you could get better and get back to hugs. Jean has a question.
Right.
And I'm going to chop this up. What are lacrimal glands?
Oh, that's what makes tears.
Okay, did I say that right?
You did, yeah.
Oh, wow, look at me. Jean wants to know, okay, so that's what that is. And then did Tim have a surgery option to begin with? Doc?
No.
No? Okay.
Well, I did not have surgery. I would think that was an option, but when they discovered the cancer, it had already, I think it was adjacent to a lymph node or a few lymph nodes, and I'm not sure why we decided not to go forth with the surgery, but I do believe that was an option. It wasn't really discussed, but in detail. But the decision was to push forward with non-surgical treatments, and I'm still here.
Yes, you are. Jeremy wants to know, is there a difference in how likely a cancer will return or not if it's beaten with those radiopharmaceuticals? Is there a likeliness of return based on that treatment option?
Yeah, so I think what's important here is for any patients with metastatic disease, the radiopharmaceutical treatments are generally considered palliative in the sense that they help control the disease, but they generally do not make it go away. For how long or what duration? Usually that's about 10 to 12 months on clinical studies. Now, there is about 10 to 15% of patients who receive a radiopharmaceutical agent like Pluvicto, where they can have long-term or durable remissions where they come off other treatments as well and do not require treatments in excess of 2 years.
One brief thing I'll add is just that we at the University of Kansas Cancer Center are proud to be opening a trial that is going to be using Pluvicto in a really early capacity in the setting of biochemical recurrence, meaning someone who's had a curative intent treatment of prostate cancer, but then has a PSA that starts to rise again, suggesting that there could be microscopic amounts of cancer present. In any case, we're going to be opening a clinical trial that's going to be using Pluvicto really early, and so we don't know what the future of Pluvicto is in terms of what it might add for different disease states and stages. So I think there's more to come, but we're so glad to be able to offer these really innovative treatments to our community.
Very exciting. Vera wants to know, when does let's watch and monitor change to let's take a look with a biopsy when we're talking about PSA results?
Oh, there are a lot of factors that go into that. So there are advanced blood testing, things called like a 4K score, for example. Imaging can help weigh into that. So depending on what someone's PSA level is, the rate of rise is very important for us to understand the risk of associated with their PSA level, and that could prompt imaging, and then imaging can help risk stratify the likelihood that someone might benefit from a biopsy to get more specific information, depending on whether there are masses or whether there are different blood flow patterns within the prostate, for example, that might suggest there could be underlying cancer. All of that is actually really sophisticated, and that's why consulting with experts makes such a difference, because Dr. Parikh and I actually don't really do much screening because our patients often come to us with a diagnosis. However, our colleagues in urology, for example, have such a sophisticated patient-directed platform for deciding between all of those options, including observation or other forms of action.
Dr. Parikh, before we go, remind us about what a healthy PSA number is, why it should be that, and when it starts to what is the number when it starts to creep up we need to be seeing.
So exactly what Libby mentioned is usually the PSA level should be less than 4. Now granted, in some patients as age advances, the PSA numbers may advance, but we usually look at PSA doubling time as well. So generally, if someone has an absolute PSA level of 4 or greater, or if someone feels a prostate lump or kind of a nodule on exam, on physical exam, that's a reason to have a biopsy. If someone's PSA doubling time is usually shorter than 12 months, it is a reason to intervene.
Should men be doing self-exams?
No. So usually it is part of a screening exam with their primary care provider once a year in the form of a physical exam.
All right. What's the big takeaway from our talk today?
I would say that screening plays a very important role at diagnosing patients with prostate cancer sooner and then offering them treatments that are curative in nature.
Dr. Wolf-Birchfield, what's the takeaway?
Sure. I would just say that even when cancer takes root somewhere outside of the organ where it came from and is metastatic, we have so many ways to help people that are meaningful and help them to live rich, long lives, and that's only getting better, including through clinical trial participation to spark that innovation.
All right, Tim, thank you for being the face of somebody being diagnosed with prostate cancer, but more importantly, somebody living with it and living well and spreading the word. What's the big takeaway from your story?
Just education. I knew little about prostate cancer, not as much as I should have, again, prior to being diagnosed. Had I known more, I would have got screened earlier. But so I would say, along the lines of what Dr. Parikh just mentioned, just get those screenings, educate men, especially men in the Black community, to get screened so that, again, it can be discovered at an early stage, and the treatment can begin at an early stage, and they won't have to get as far along as I was before getting my treatment. So, yeah, just education, get the word out.
All right, Tim, appreciate you very much. Be well. Thank you so much.
Thank you.
Thanks to our docs for being here with us today. Always appreciate your insight, and thanks to our viewers for your great questions. We'll see you back here tomorrow. Brain fog pushed an accomplished pianist away from the keyboard. What she thought might be Alzheimer's was actually her kidneys. I'm Jessica Lovell on the next Open Mics with Dr. Stites, the surprising side effect of kidney transplants, how a new healthy organ can change what's happening inside your brain. Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.